Right. Oh, you are recording. Please be sure to let everyone know they are being recorded. Guys, you are being recorded.
Okay.
Yeah, it comes up on the screen.
And it's got, I don't know why it says I've been doing it for 10 minutes. It's a bit bizarre, isn't it?
Oh, you're echoing now.
Emma, how are you coming? You're coming in again.
Oh, hang on.
Oh,
Yeah, I think we're echoing because of Emma's weird computer.
No, Emma's come in the meeting twice. That's why.
Hang on. I've got to try and work something out. Dismiss. Oh.
you're cloning yourself.
Oh. Okay. Well, I can see you all now.
Oh, good. We can't see you.
Wait, where the hell are you, love?
On the beach. In the Caribbean.
Oh, maybe I need to... Oh, hang on. Oh.
I think your camera's off, hun.
On incoming. Okay. Well, I can see you guys.
Well, we can hear you.
Well, you won't be able to see me on the beach.
No,
What's
I
going on
can't
with
do
your
that
computer?
either.
So I guess as it's 5 past, everyone else is busy. So the point of recording it is that no one can ever, no matter when we set these meetings, everybody is never going to be able to get here. Oh, Emma's here. Hello, Emma. Hi.
Oh.
So I think we'll make a start. And if people join, we'll just kind of ask them if they want to catch up. So the point of this discussion is frailty. I uploaded the video and stuff onto the website. I don't know if any of you have had a chance to have a look at it and if it's any use.
With the scoring, yeah.
So there was kind of various tools and PDFs and stop start and stop frail and loads of different things you could use if you wanted to. And I think the reason frailty is what I picked is because the trust is doing a big push on frailty. There is a feeling that frailty is a bit like sepsis. If we don't look for it, we won't see it, we won't treat it well, and at the moment we're perhaps not as aware of it as we should be. So there are lots of different things going on to try and make everybody in the trust more aware. Oh, Grace, someone's joining you on the beach.
Yeah, it's Melanie. Hang on.
Hi, Melanie.
Oh, the two of you on the beach.
Your head's going to appear on the beach any minute. Oh,
That is just the weirdest thing, watching you girls go in and out. That's hilarious. What? We're on the beach. Oh, are we? Oh, look.
So Melanie's not on the beach. It's just you,
Yeah,
Grace.
I've got her on the beach. I can see her.
Oh, you're both fading in and out of the beach.
Yeah.
I was on the beach 12 days ago. Oh.
God, wouldn't that be nice? So yeah, the trust is having a big push on frailty, which means in theory, all the staff on the wards over the next few months should become much more aware of this. So it's quite easy for us to chat about stuff and to bring ourselves up to speed because we're a smaller number. You can imagine what a mission it is to get every HCA nurse member of the MDT up to speed. So the trust is doing a big push. There's going to be a frailty strategy. There's loads of new training material, and they want lots and lots of QI projects to try and improve our care. They did a baseline audit and felt that we weren't very good at identifying it, and they asked staff, and staff said they weren't very confident about frailty. So that's where all this has come from. And the trust has made a few key decisions. They want the Rockwood score to be the shortcut of how we communicate how frail someone is. So we all need to be super confident, because I think it's going to come to us to score them. And we might get from the acute a shorthand that says this person's got a Rockwood score of 6, and that needs to mean something. And then there are going to be lots of new ways of looking at frail people and making sure we're not missing things. And Emma and I have been working with Meds Management to do a QI project at Arundel that I'll get her to tell you about. And we're hoping there'll be more QI projects so that we can kind of work out what the best approach is from a medical point of view. If each discipline tweaks what they're doing so we get as good as we can get, so the doctors do it, the pharmacists do it, the therapists do it, then overall we'll have a really, really good approach across the trust to help frail people. That's the plan. In fact, the ideal is that eventually the whole system will work together to sort out frailty. Oh, hi, Johnny. I have to warn you, you're being recorded, and Grace and Melanie are on the beach. So by all means, play with your background and try and go to the beach.
I haven't got a flashy computer.
Gerbrig's limited. She's got to just sit in a music room. So we're just saying that the trust is having a huge push on frailties. You might hear a lot more about it. So the reason that, I mean, this live discussion session, the only thing that I wanted to cover other than catching up with you all was to make sure that the Rockwood scoring is something you're comfortable with, because I think it's going to fall to us to do that, and it's going to be key for everything going forward. So if we design a pathway that's for mildly frail people, it will be based on their Rockwood score. And if we start doing a certain pathway for people who are severely frail, it'll be based on their Rockwood score. So getting that number right is absolutely key. So Emma, do you want to tell them about the frailty project we're doing, just so that I'm not talking all the time?
Yeah, so myself and Sue are doing a QI project, so just based at Arundel, and it's really come through the background more so around my dissertation bits, which I know you guys I've spoken to you already about my dissertation. So we are to pilot 10 patients here at Arundel that have come in with a frailty syndrome. So they've either fallen, have reduced mobility, have new or troublesome incontinence, have side effects from medication, or have a new confusion or delirium. So they've got to have that as their baseline of an admission cause. And once they're identified, then they have to have a Rockwood between either 4 at the minimum to enter into the pilot, or I think we said about 6. So they're the patients that we should be able to make a difference on. So there's 2 things going on with this pilot. The first one is from the medical point of view, that these patients will enter into this pilot if they have a syndrome, if they score between 4 and 6, and they will get an enhanced comprehensive geriatric assessment, more of an in-depth that we're doing now. So we still do the Clarkin Performer, but from that, there's some additional questions which are very much based around what we're already doing, but they have maybe a bit more in depth to them. And then once we've identified, so I did one on a patient the other day and basically identified that she came in following actually a side effect to her medication. And then I talked to her about kind of what her risk of readmissions are, and that's around falling over. She had never seen any of the frailty teams out in the community, and this is a lady that lives in Central Worthing, so I know they've got frailty nurses, or the sort of proactive stuff. So I spoke to her about that, and she was very keen to actually kind of be involved in that. I spoke to her about what frailty meant, and what that means for her as a patient, and the concept. So some of the things which normally would have come out, I'm absolutely sure, and I've not referred anyone to proactive care or frailty team for absolute ages, and I'm looking at Grace and probably Melanie, because they both know the concept of, in terms of the community, because all 3 of us have worked in the community. And then, so that was really positive. And then Helena Simpson, who is one of the proactive pharmacists, is doing the meds review. So then she did a frailty meds review on this patient when she came here on Monday. So the idea is basically to identify 10 patients, do the study, see what it brings out, and see what maybe we might do differently, or things that maybe aren't done any differently and it doesn't contribute anything to our assessment. So I've only found 1 patient appropriate, ridiculously enough, in Arundel. Gervin will agree. We've had like ridiculously young patients who none of them got any frailty syndromes this week, which is just hilarious because
Typical.
This is unusual. Yeah, so I'm like, come on, frail patients, where are you? So we'll just see. It's obviously early days. We've only started last week. So.
And we're just trying to work out if doing a kind of mini CGA actually pulls out new information, or is it just repeating a conversation you've already had and a total waste of time? Because what we don't want to do is change our normal medical clerking just to make it more arduous. I don't want to add in yet another tick box, yet another form that actually adds nothing. So what Emma's helping me do is work out, actually, is that mini CGA tool, which is in the resource pack, is that helpful, or is it just yet another thing to do? So we'll let you know how it goes. It's going to run as long as it takes to get 10 patients. And if it carries on like this, that might be a while. We thought it'd be a few weeks. And then alongside that, the pharmacy, the medicines management, are having a big overhaul of how the ward pharmacists work, and they're really excited at the thought that the ward pharmacists might be able to do medication reviews that are a bit more tailored to frail people, and actually be able to contribute more to their clinical plan. I think we might have lost Mel and Gray, so bless them, they'll probably come back in a minute. I don't know, Johnny's talking to someone else, but he's muted. Oh, are you talking to us? I think
No, he says he wants to be muted. Yeah.
Okay. So yeah, it's an interesting way of testing new things, and I think if anybody else wants to test new ways of working or wants to have a go at this kind of project, I can do most of the paperwork. I just need whoever's allowed to be patient facing, which currently is me, to actually try things on patients. So that's hopefully going to give us some really interesting results. And working in a new way with medicines management has been really interesting because they think about things totally differently. So just the conversations about how do you currently deal with frail patients? What questions do you ask? I learned so much listening to them thinking, my Lord, my medication reviews have been dreadful. I haven't been doing anything that they're talking about. So I think there's a real benefit to working with other disciplines because you pick up those tidbits and think, well, I haven't got time to do all of that, but I could do that and I could do that. So we'll let you know how we get on, but we're both finding it interesting. Well, I am. Emma, you'll probably run off your feet, but
no, it's fine. It's fine. I think it's just this particular week has been, well, since the end of last week, the patients just haven't fitted into the frailty syndromes. They will come. It's just one of those things.
But the only thing with the Rockwood score, which in particular in the last 6 to 9 months, I think is really difficult. Every patient that you clerk and you ask, what is your normal mobility? Everyone says pre-lockdown or post-lockdown. And then you go like, okay, which one do I take? Because these people haven't suddenly been moving since March because they used to trot off to the shop, but now they haven't done it. And then quite clearly with OT and physiotherapy, they say, well, they will never get back to their previous score. But it's quite interesting also if you see the clerking from the hospital, because obviously some doctors still take the pre-COVID as their mobility, and then your score is much better. And some people take, the week before they came into a hospital when they already had a fall or whatever. So I think the only difficult in all of this will be lockdown, and I think we're probably heading to something else again in the winter. I think because if you read all the research and how you improve frailty outcome is they say 25 minutes of exercise 4 times a week. They're not even getting across the front door. So I think that's the only real difficulty. You nearly need to have 2 Rockwood scores and say, well, up to 6 months ago they were able to do this. Is it realistic that we say, okay, their score should be that? For example, we've got a very young lady with a Cordell-Quiner syndrome. She's possibly got potential to be what she was previously after her surgery, but a lot of other people, I think, well, they've lost it. They unfortunately will never get it back.
And that's one of the things I'm not reading about lockdown, but actually it's a really important point, is that our frail elderly population were told to stay in, and by not moving, they're going to lose function.
Yeah.
So everybody talks about the unintended consequences, the non-COVID consequences of lockdown. But for us in what we do, these poor people who haven't done much for 6 months and might be told to do that again, stay in the house, they're going to lose the ability. So I don't know what you guys think, but I suspect we're going to have to do what they're able to do, because, what they were doing 6 months ago is almost irrelevant. If they've barely moved for the last 2 weeks, I don't know how easy it is to say, what could you do if you were allowed? I mean, that's kind of a strange conceptual thing, isn't it?
Oh, most people, I have patients who say, well, we used to walk up Snowdon, and you say, well, when? I go, 1985.
Yeah.
I mean, that's probably anyway,
it's also being realistic. I think some of these people are not realistic, or they keep forgetting. I think that's the only difficulty, and that's the difficulty I've found in the last 6 months. Don't know about it.
I think if these people have if they don't have pre-existing frail conditions, they're going to have that resilience to bounce back, aren't they? Whether they've had 6 months of not doing very much. It's a bit like me. If I've done no exercise for 6 months and I decided to then go and do a marathon, I would obviously struggle, but probably could do with enough training. These people just don't have it. And you're right, Gary, what people tell you. And then when you actually question it, you're a bit like, you haven't done that for years.
And I guess, and part of the Rockwood is about how much help they need. Maybe they can't have the help they need. So they might say to you, oh no, I do everything for myself, but that's because nobody's allowed to come into their house, not because they would normally do that. So the Rockwood score, because there's a lot of, I was trying to find easy ways of doing it, and the handout that I sent you guys out that we were going to talk about was comparing it to what activities of daily living, the simple ones and the more complex ones, what can they do? But it's really interesting perspective, because if you say to someone, do you do your own shopping, do you do your own cleaning, they might have to, because they're not allowed to have care.
Well, or the other way around, they said, well, pre-lockdown I would trot off to the shop, but now I get it delivered.
Now my daughter brought it off. So I think it's going to be really, really difficult, and that might skew our scores. And that's a really important thing if we're going to start only offering treatment to certain Rockwood scores. That suddenly becomes really important, because I wouldn't want to deny somebody because lockdown makes them look more frail than they are. I mean,
well, and then adding on, in the past when we had 2, 3, 4 weeks sometimes, because that's what I keep hearing from the physiotherapists, they say, well, if I had time, we can speak, we can get them back to whatever they were. But obviously now that we're a bit pressed to get them out within 2 weeks, it's not going to happen. I don't know.
We don't have a lot of time to help them. And I was talking to the therapists about this, and they were saying, well, we have community colleagues, but it isn't normal practice to stop halfway through a course of treatment and hand to someone else. So perhaps we need to somehow negotiate, well, what would their full treatment look like? And if we can only do the first few days, can we get someone else to do the rest? In theory, there are loads of therapists in the community. I don't know if in real life they actually have all that capacity, but I guess that's what we should be aiming for. Like if someone's discharged quick and we haven't finished doing the medical stuff, hopefully we can ask the GP and the community teams to continue it.
I think, Sue, my experience with the community is if we were going to hand the care over, you're going to have this massive gap between us finishing doing our bit and the community services picking up, which can then be anything up to 6 months, certainly with community physio. Yeah.
And got up to 6 months. I mean,
that's
not going to remember what they were doing.
Yeah.
That's not really a solution, is it?
No.
It's not the same, is it, community physio anyway, because they only get like maybe once or maybe potentially 2 visits a week for a very limited period, and then the patient has to have that motivation or ability to do their exercises, what we would have recommended for them anyway to do on their own. And I think when they're out of the hospital environment without a tech with them encouraging them, I don't think people just go kind of back to their old ways really and don't bother. So
and it can be easier for a care home to just sit somebody in the chair or the bed. So sometimes they're actively discouraged. No, don't stand up, you're at risk of falling, which we can understand, but that just encourages the muscle wastage, doesn't it?
Yeah.
So we need to know what resources are out in the community. Are you guys getting a sense at the moment of whether there are plenty of people waiting to pick people up as we discharge them, or?
No,
I don't think they're out there.
I mean, I certainly don't think GPs, because I feel loath to ask GPs to do things, because there seems to be a flavour of, we're at capacity, we're totally frazzled, don't give us anything to do.
Yeah.
I don't know if the therapists and the nurses feel the same, presumably.
I definitely from the from the nursing point of view, obviously we try and get the patients to be able to do as much for themselves as possible, so the community nurses don't have to go in, so doing their own injections and that kind of thing. But if someone needs a nurse to do their insulin, or they need something, then the community nurses have to pick it up. There isn't a choice. And I know the therapists have been referring to responsive services for ongoing OT and physio and things, but I don't know what the follow-up is, like how quickly then they're seen, or if they get any input.
And I think speaking to my colleagues that I know in responsive services in Worthing, the therapists especially are overrun because of Home First.
Oh, really?
Yes, absolutely.
I've heard a lot of people on the Home First waiting list. I didn't know that was sucking therapist time.
Yes, sucks them dry.
Yeah. So I guess we have to try and do what we can within our setting, but it's going to be difficult if we can't hand over to anyone. And if you come across any specific things that you're struggling with, please let me know, because I've got time at home to start chasing around and getting in touch with people and trying to sort out filling any gaps. So